Hello everyone. Today I'll be discussing about how to assess the COC or cumulus oocyte complex and oocyte quality in IVF program. This is the outline of my presentation. I will start with explaining the structure of oocyte, its morphological variations and how to assess them. Then I will discuss about the impact of patient pathology on oocyte quality and to inseminate or not to inseminate the poor quality oocytes. And finally, I will discuss some of the strategies to improve fertilization outcome in poor quality oocytes. It has been suggested that the relative contribution of oocyte to a successful live birth is much higher than the contribution from sperm or endometrium. That's why we should know more about oocyte so that we can get better fertilization, good quality embryos, and good pregnancy in our IVF program. In IVF lab, oocytes are first seen with the cumulus mass. Together, it's called as COC or cumulus oocyte complex. The cumulus cells are derived from the granulosa cells within the follicles, and they play a crucial role in maintaining the health of the oocytes. These cumulus cells establish connections with the oocytes through the gap junctions and responsible for the bidirectional communication between the ovary and oocytes. Overall, the health of the oocyte is related to the quality of the cumulus cells. Hence, the cumulus oocyte complex assessment or COC assessment is considered as one of the important steps in IVF techniques. Why oocyte assessment is important in ART? The quality of oocyte is influenced by several factors. Normally, the controlled ovarian stimulation recruits both good and poor quality follicles. Multiple follicles are being stimulated. It may contain the good quality as well as poor quality oocytes. Also, the development of the follicles during the stimulation process may not be synchronous. Apart from this, the ovarian pathology will also affect the oocyte quality. Consequently, the embryologists have to deal with oocytes of different qualities. Hence, the oocyte assessment will help in segregating the oocytes based on their morphology. Specifically, it helps in the assessment of the maturity level. Then decide about the time of insemination. If the OCC are post-mature, insemination should be done immediately. If they are immature, can allow more in vitro maturation time. This will also help us in understanding the anomalies in the oocyte so that we can select or deselect such oocytes for fertilization. In IVF patients, we do see variations in quality of oocytes. A healthy human oocyte measures about 100 to 120 microns. Spherical in shape, with a clean homogeneous cytoplasm and an appropriate size polar body, as you see in this picture. In a routine IVF procedure, the primary assessment happens as soon as the follicular fluid is received in the lab. The secondary evaluation happens prior to ICSI or after denudation of the cumulus mass. Conventionally, the oocytes are assessed for their shape, the size, the zona pellucida, the cytoplasm, and the polar body, the perivital space, and also the surrounding cumulus cells. There is also a possibility to assess meiotic spindle, the apoptosis of cumulus cells, the secretome profiling, but these parameters are quite complex and are not routinely done in IVF lab. COC assessment involves the size of the cumulus mass, its expansion, and how it appears. Usually, the immature oocytes have few layers of cumulus oophorus, as you see in the first picture. Having a well-expanded cumulus mass with a radiating corona is suggestive of oocyte maturity. But remember, sometimes it may not be correlated with the nuclear maturity, as you see in the second picture, though the cumulus mass is well expanded, but the polar body is not seen in the perivital space. The third picture, the cumulus cells are almost similar to the second one, but we can appreciate the first polar body at 2 o'clock position. On the extreme right, the oocyte has dark cumulus, which is suggestive of post-maturity of oocytes. But nuclear assessment is confirmatory, which can be done once the cumulus cells are removed from the oocyte. The first picture shows a GB oocyte, the germinal vesicle oocyte, the most immature form of the oocyte. The second one is also GB, can still appreciate germinal vesicle here, but the difference is the nuclear membrane is not as prominent as you see in the first picture. That means the GB oocyte is possibly approaching the GVBD, the germinal vesicle breakdown. Hence, the nuclear membrane is not clear. Once the GVBD completes, the oocyte is now called as metaphase 1 stage. As you see in this picture, there is no germinal vesicle and no polar body in the perivital space. Here we have a mature human oocyte, which is in the metaphase 2 stage. The second picture, we can see polar body at 6 o'clock position, which is seen under polarized light. Though the second and third picture look similar, there is a difference in the meiotic spindle. The meiotic spindle and first polar body here, the first picture they are connected. They are separated. Whereas here, the third picture, they are almost together. That means the oocyte is in the telophase of the first meiosis. This is not yet a fully mature oocyte. And if ICSI is done on this oocyte, thinking that it is metaphase 2, there could be a risk of abnormal fertilization. Human oocytes tend to show some variations in their size. The size is extremely large. It is considered as giant oocyte. Sometimes these oocytes also have two polar bodies, as you see here in this picture, and two sets of meiotic spindle. Hence, such oocytes should be excluded from insemination as there is a higher risk of getting the genetically abnormal embryos. Apart from size, the shape abnormalities are also seen in the human oocyte. The elongated oocytes, are also known as the ovoid oocytes, are considered as dysmorphic oocytes. The extent of elongation is represented in Ri, or roundness index, which is nothing but the length divided by width. The top image here has a roundness index of 1.02, which is almost circular. On the other hand, this oocyte has a roundness index of 1.5, which is a dysmorphic one. There are several reasons for this dysmorphism. It could be due to ovarian pathology or suboptimal follicular microenvironment, or many times it could be due to iatrogenic, maybe stress during oocyte pickup, denudation, or pipetting can also stretch the oocyte and make it dysmorphic. But interestingly, this variation is not known to affect the fertilization, but the cleavage pattern is slightly affected. On day 2, such oocytes will have a flat array of blastomeres. There could be some delay in the development, but there is no impact seen on the blastocyst quality and subsequent implantation potential of the embryo. I will now discuss about the extracytoplasmic dysmorphism. This extracytoplasmic dysmorphism in oocytes includes zona pellucida defect, the first polar body morphology, the perivital in space, size, and the granularity, the discoloration of the zona pellucida, and the shape anomalies. So these anomalies are more of phenotype deviations, and I will take you through the individual abnormalities in detail. The zona pellucida protects oocyte and embryos until day 5 of development, and zona pellucida is a glycoprotein matrix. Any variations in zona pellucida is normally due to secretion and patterning problems. And images shown here are some of the variations seen in the human oocyte. We see a thick zona pellucida and a septate zona, and it's a duplication. And here is a discoloration of the zona pellucida. So zona pellucida scoring is done normally if the zona pellucida is extremely abnormal. If it is too thick, unusually thick, or if there is too much of discoloration, and then it should be documented. Otherwise, there is no specific benefit to measure the thickness of the zona pellucida, and there is not much of evidence to prove that the zona pellucida abnormalities do have abnormal reproductive outcome, and the variations are many times they are patient specific. The perivital space is the space between the zona pellucida and the ulema. The perivital space starts appearing during the oocyte maturation. As you see here, normally the immature oocytes do not have, especially GB oocytes, have very minimum perivital space, and as and when the oocyte undergo maturation, the perivital space is being formed. The large perivital space is suggestive of over maturation of the oocyte. We can consider PVS as large when it fits the size of 2 or more normal size polar bodies. Then we can say the perivital space is large. And sometimes in the lab, or the osmolality changes in the culture medium can also lead to large perivital space. The enlarged perivital space is often observed together with the abnormally large first polar body, as you see here in the third picture. The perivital space sometimes contains inclusions or debris. We do not know why exactly it happens. It is suggested that the over-maturity of oocytes or stimulation protocols may be responsible for these inclusions. But there is no need to count these inclusions or debris. But if there are multiple inclusions, then this should be documented. Sometimes the first polar body fragmentation can also appear like inclusions, and it's difficult to distinguish. The impact of the inclusions or debris in perivital space is not known, but it has been shown that the higher level of the debris or inclusions may have some impact on the quality of the embryo, but there is no conclusive evidence on this. The polar body is a dynamic structure located in the perivital space, and it is the byproduct of meiosis. The size of the polar body should be always proportionate to the size of the oocyte. The polar body can also undergo fragmentation, as you see here in this picture, and that get confused with the inclusions or debris in the perivital space. It has been shown that embryo derived from oocyte with an intact polar body has a higher chance to undergo implantation and pregnancy compared to the fragmented polar body. It's also shown that the large polar bodies are usually due to the meiotic errors, and embryos from these oocytes are at a higher risk of aneuploidy, and they should be avoided for insemination. Here you see oocyte with the large polar body and fragmented polar body, the large polar body and the fragmented polar body and abnormally sized polar body, and this kind of oocyte should not be inseminated. Let's discuss about the important intracytoplasmic factors in oocytes. This includes the dense central granulation, refractile bodies, incorporations, the vacuoles, the aggregations of smooth endoplasmic reticular cluster. So I'll be discussing all these one by one. In some oocytes, the oolemma or the ooplasmic membrane is very weak and completely lack elasticity. So during ICSI, we don't feel any resistance when oolemma is pierced, and the pipette just goes in, which eventually leads to the leakage of ooplasm and degeneration of the oocyte. And these oocytes are called as fragile oocytes. The fertilization ability of fragile oocytes are much lower than normal oocytes, but once fertilized, the embryo developmental ability is same as normal oocytes derived from embryos. The cytoplasm reflects the oocyte health. A healthy oocyte should have homogeneous cytoplasm. The most commonly seen cytoplasmic abnormality is granulation. The mild granulation is suggestive of some kind of stress in the oocyte, whereas highly granular cytoplasm is suggestive of poor quality oocyte. Hence, fertilization and developmental potentials in this type of oocytes are significantly compromised. In some oocytes, the granulation is localized to certain areas. As you see here in this picture, it's typical of organelle clustering, and such oocytes have very poor fertilization rate, and embryos derived from such oocytes have compromised implantation rate, and also there is a higher risk of aneuploidy in the embryos derived from the severe form of central granulation. The SCR, or the smooth endoplasmic reticular cluster, is one of the most important severe cytoplasmic abnormalities of metaphase 2 oocytes. They look similar to vacuoles, they're almost similar to vacuoles, but when SCR is seen, the sibling oocyte should be carefully examined for the SCR disk. It has been suggested that the normal perifertilization activities, which involves calcium signaling pathway and mitochondrial bioenergetics, are positive when the oocyte has the multiple or the large SCR clusters. And normal perifertilization activities, and in addition to this, the normal fertilization can attend if the SCR clusters are not ruptured during ICSI. So you should avoid damaging the SCR cluster while performing the ICSI so that we can have normal fertilization. Though it was suggested earlier that SCR positive oocytes carry significant risk of fetal abnormalities, as imprinting errors, anomalies, but there is no conclusive evidence so far. So that means we can fertilize SCR positive oocytes, but prefer transferring the embryo from SCR negative oocyte, or it should be the last option when no other embryos are available for transfer. Another common cytoplasmic abnormality is vacuoles. The vacuoles are fluid-filled structure. They could be either small, as you see in this picture, or they could be large, or there could be multiple vacuoles in one oocyte. The small vacuoles of less than 5 micrometer diameter are not detrimental to oocyte, whereas large vacuoles more than 14 micrometer are associated with the fertilization failure. The multiple vacuoles can lead to displacement of the cellular organelles, which may eventually carry risk to the embryos. I have this table which summarizes the type of morphological variations and their impact. As stated here, some of the abnormality morphological variations, such as the dark color of cytoplasm, the homogeneous granularity of cytoplasm, and the ovoid shape, have minimum impact on the reproductive outcome. Whereas oocytes with the refractile bodies, the fragmented first polar body, the dark zona pellucida, the large perivital space, and debris in perivital space have moderate negative impact on fertilization and the developmental competence of the embryo. Whereas oocytes with the large cytoplasmic vacuole or multiple vacuole, the severe central granulation, and clusters of smooth endoplasmic reticulum may have significant negative impact on the reproductive outcome. Next, I will take you through the impact of patient-related factors on oocyte quality. We all know that the aging is known to affect the female fertility by reduction in ovarian reserve and number of oocytes gradually decrease over time. But apart from oocyte number, aging can also affect the oocyte quality. Specifically, aged oocytes have increased vacuole, they altered mitochondrial matrix density, they also have increased incidence of dilated or dissociated smooth endoplasmic reticulum, they have increased incidence of dilated the Golgi complex. Apart from patient age, in vitro aging of the oocyte can also affect the structure, the ploidy status, and the functional competence of the oocytes. So we need to be extremely careful to avoid aging of the oocytes in vitro to protect the cellular organelles and the functionality of the oocytes. Altered maternal metabolic conditions can affect follicular microenvironment, so thereby affect the oocyte quality. High BMI is known to affect the oocyte quality. Interestingly, PCOS per se has no impact on the oocyte quality, but PCOS patient with a high BMI, there could be impairment in the oocyte quality. The endometriosis is another important cause of female factor infertility. Several studies have shown that the oocytes experience oxidative stress in patients with endometriosis. Apart from impaired oocyte quality, their functional ability is also affected due to impairment in the cellular structure. The cancer can affect the oocyte maturity. It has been shown that the number of atretic oocytes are significantly higher in cancer patients compared to control, and specifically among breast cancer patients, the oocytes have multiple anomalies, both extracytoplasmic and intracytoplasmic anomalies are very common in the breast cancer patients. Now the most important question is whether to inseminate or not to inseminate poor quality oocyte. So here I suggest that if the oocytes, the abnormality in the oocyte is very crucial to decide whether we can inseminate or not. For example, the oocyte, giant oocyte, the size is more than 200 micrometer, the extremely large perivital space, the fragmented oocyte, extremely large polar body should be avoided because there is a higher risk of abnormalities in the embryo. Whereas oocytes with a SCR disc, the vacuolated oocyte, the severe central granulation can be inseminated or injected with caution. Whereas some of the abnormalities like the thick zona pellucida, the mild granulation, refractile bodies, the PVS inclusions, the fragmented first polar body, since these anomalies have minimum impact on the outcome, they can be injected without any problem. Now the question is, when you have poor quality oocytes, can we improve the outcome? So what are the strategies? It has been suggested that the poor quality oocytes are more vulnerable or susceptible to experience stress, especially the iatrogenic stress, the stress they experience in the lab. Maybe during pipetting, denudation, or our in vitro conditions may do more harm to poor quality oocyte. So we have to be extremely careful to avoid stress to the oocyte during the laboratory intervention. And use of appropriate laboratory intervention, the adjuvants can be used. Like in case of fragile oocyte, one can consider to go for the piezo-ICSI, where the risk of degeneration is very minimum. The assisted oocyte activation is also another approach to increase the chance of fertilization if there is a defect in the calcium signaling pathway in the oocyte. And most importantly, the good laboratory practice is the best way to improve the outcome in poor quality oocytes. As I stated earlier, one of the important reasons for failed fertilization when such oocytes, the poor quality oocytes are injected is due to defective oocyte activation. About 60 to 70% of the time, it is due to defective oocyte activation. And defective oocyte activation is primarily related to the calcium pathways, the signaling pathways. As we know that the calcium, the pathway, the oscillations play a very crucial role in the process of fertilization. The calcium, once the sperm enters, then that gets activated, that acts on through certain pathway, the PLC zeta acts on PIP2, it dissociates and produces inositol 3 phosphate. The inositol 3 phosphate binds to the receptors on endoplasmic reticulum. The endoplasmic reticulum is filled with the calcium. This calcium gets released to the ooplasm, and this calcium it is involved in multiple functions. So any of these issue, any problem during the process can have significant negative impact on the fertilization process. It's also known that the routine techniques what we do in IVF lab, such as in vitro maturation of the oocyte, the cryopreservation of the oocyte, can also affect the calcium oscillation pathway. Here you can see the calcium, it should follow a very unique pattern. And if this pathway, the pattern is disturbed, then the fertilization is compromised. So then one can consider using assisted oocyte activation using the calcium ionophore activation. The studies have shown, though the calcium assisted oocyte activation is primarily used for sperm mediated activation failure, It can also be considered in case of poor quality oocyte. Studies have shown that the assisted oocyte activation can significantly increase fertilization rate and increased fertilization rate and also increased implantation rate. So in summary, I would like to conclude by saying that the assessment of oocyte is a crucial step in identifying the quality oocytes, and subsequently it can help in the embryo selection. The endogenous factors such as patient pathology can influence the oocyte quality, and the poor quality oocytes have increased susceptibility to iatrogenic damage. Hence, care should be taken during the laboratory manipulation of the oocytes. And use of adjuvants such as the assisted oocyte activation or piezo can help in overcoming fertilization failure in poor quality oocytes. Thank you very much for your attention.